Well, welcome everyone to this quickly but very well-prepared meeting, stakeholders meeting agenda for our resident patient care, senior care in hospitals, post-acute, and long-term care. The meeting's starting promptly at 2, and we will finish right at 3. We have some excellent speakers, and we will be asking that each speaker limit their time to about 10 minutes, and we'll notify them at the 10-minute mark. If you can go less than that and make your points, please do. At the conclusion, we'll have a few moments of question and answer for each other. Everyone on the call is an expert. And we want to be thoughtful about not just discussion and information exchange, which is vitally important, but even more important are action items. What can we do from our individual association space, organization, or department? And what even more importantly can we do as a collaboration of people interested in the best care for our resident seniors and those who are frail in Florida? So right now, all the attention seems to be on testing and rapid testing, especially in the community and in hospitals. So at this time, there's rather a national dim light in the long-term post-acute arena. But as soon as our frail and elderly start to be inoculated with this contagion, the bright spotlight will be right on long-term care and post-acute, as it was in Kirkland, Washington, where the nursing home had a concentration of deaths. So let's get right into it. So speaking on behalf of FMDA, Dr. Saunders Cepeda, Diane, if you'll just start off and give us your thought about the long-term care continuum.
Yes, thank you, and thank you all for joining us on this call. As Dr. Hock said, it really is our goal to align with the state and all of our stakeholders and create an action plan. We do know from the lessons that we're learning from Washington State with the outbreaks there, as well as what we've seen in New York State with the surge there, we learned that we want to avoid any mandates that do not address the unique challenges and risks that the nursing facilities are facing, and that would acknowledge that post-acute long-term care does not only exist in the nursing facilities, but has a broad continuum that we need to be prepared for as well. One of the main things that we have as we're looking through and as an organization trying to determine what we need to do, we want to be able to formulate some clear and transparent coordination with our hospitals so that we can see where we need to have these residents go when they are either returning from the facility, from the hospital back to the facility, or going out from the facility to the hospital. You know, we want to understand how do we get that bidirectional flow? Where are the alternative settings that we may need to place a person who is requiring skilled services if that facility can no longer maintain and treat that person in place? You know, understanding that just as with our hospitals and in our other settings, there are shortages and concerns that our nursing facilities are facing. So we want to be just privy to that and be prepared. Our whole goal is to be prepared and achieve collaboration between the state, all of the stakeholders who are on this call, as well as the stakeholders who are not on this call, so that we can have a clear, transparent, and proactive coordination, you know, to address what we're going to see in a few weeks in our nursing facilities. You know, I don't want to be the key person speaking. I know we have a lot of speakers, so I'm actually going to limit my comments to that, Dr. Hock and Ian, and maybe we can move forward with some of the others so that we can hear from everybody.
Well, thank you, Diana. We want to come back to you. You're just such an expert and well-versed in this. So we do want to have action items that touch on the importance. So moving right along, actually very quickly, so there is time to develop your thoughts and share with all the participants. So Secretary Mayhew, Assistant Secretary Molly McKinstry, and Kim Smoke, that we all know so well as the Chief of Field Operations and Survey. So let's turn it over to Aka and hear about your COVID-19 preparedness and thoughts. Secretary?
Thank you very much. This is Mary Mayhew. I appreciate the opportunity to present, to join all of you, and to have this vital conversation. As many of you are aware, we've been having regular, frequent, weekly, multi-week, multiple calls throughout the weeks, over the last several weeks, with providers throughout the state. But let me start where the governor's office has long been. And that is recognizing the great risk that COVID-19 poses to our most vulnerable individuals in this state. And that we have been determined to protect our elderly, to recognize the risk that this poses to those with underlying medical conditions, and that we have sought to stand guard at our long-term care residential providers to appreciate the level of disruption that this is posing to the healthcare system, to the delivery of services in our residential subacute settings. We were early in our efforts to restrict visitation, to require screening of visitors and employees and vendors, and of course, increasingly to really close down that exposure from the public to best protect our elderly and the staff caring for them. And we have always acknowledged how challenging that has been, how isolating that is. This is, as you all know, and you live daily, how critically important that family and community engagement is to your residents. But we understand how vitally important these actions have been to reduce, to try to prevent the infection from coming into the facility, to reduce its spread. We understand how this can spread like wildfire within a facility. So everything that we have done at the state and engagement with our partners and providers throughout the state has been focused on how critically important these efforts are to supporting with vital resources our long-term care providers, to understanding the need for PPE, for clarity and the guidance and the changing guidance that has been coming out from the federal government over the last many weeks as we continue to get a picture of the impact of COVID-19 on our country, on our state, at the county level and at the community level. What I also have acknowledged frequently on these calls is the friction that this has created in the discharge planning process. And we have worked diligently with our hospital and residential providers. We have worked closely with the state associations, and I want to commend the state associations for their leadership, for their collaboration, and their willingness to look creatively at how best to support the patient-centered and resident-centered approach, to acknowledge that we are in unprecedented times and the challenges that this has created to the delivery of these services, both in the hospital and in the subacute setting. We have worked closely on improving the delivery of information, the exchange of important information when a individual in a hospital is ready for discharge. But here's where we are. we know that for our skilled nursing facilities, our assisted living facilities, and other residential providers, that they must consider that anyone being admitted into their facility, regardless of whether or not they have tested positive for COVID-19, that they are at risk of having the virus, and of course what that poses as a risk in terms of the transmission within the facility. For our hospitals, as they prepare for this surge, and we know already that is being felt acutely in Miami-Dade, in Broward, in Palm Beach, and starting to see increases elsewhere in our state, in Hillsborough and in Orange County. They are looking at every bed and trying to prepare and have the necessary capacity to meet the demand, to be able to look at every bed and every room for its potential to become an ICU bed, an ICU room. And so as they do that, we have this challenge that we are all struggling to deal with and to work in the best interests of that patient-centered, resident-centered approach to their clinical needs, their care needs, and to assure that when an individual is ready for discharge, that the receiving facility is able to support the level of infection prevention and control that we expect, focused on necessary isolation and availability of PPE. And we know, and we have said this, I've said this throughout the press conferences that I've held with the governor. I've said it throughout in all these conference calls. The standard today that is expected of our long-term care facilities around infection prevention associated with COVID-19 far exceeds what most of our skilled nursing facilities and certainly our assisted living facilities are prepared to provide. Now, many have absolutely worked determinedly to be able to meet some of these standards around isolation, and certainly to acquire and train their staff on PPE. But we still find ourselves in areas of the state with the challenge of the appropriate decision-making, clinical decision-making around discharge, again, to support the needs of the hospital, to assure that there's capacity. And let me also say, we all know that an extended stay in a hospital bed when someone is no longer at a hospital level of care, that's not in their best interests either. So I would first say that we've been working, again, closely with the associations, great work around a document that was developed to support good communications around transfer. There have been a number of efforts regionally to support increased communications between our hospital providers and our skilled nursing and assisted living providers to support appropriate discharges. My agency, along with staff in the associations, have been working on individual cases to try to facilitate appropriate transfer and placement. I suspect that as we continue to evaluate the challenges that we're facing, we are considering what may be needed regionally for dedicated recovery facilities that are able to support isolation and care that is in a step-down capacity. I would love to say that we've got that plan and have identified those facilities, but we do have a lot of people who are working on what that may need to look like, what the clinical care model may need to be, and certainly all the other services and supports in terms of the meeting dietary needs, the environmental cleaning, all of the staffing supports that would accompany that. I think it's just, we must acknowledge that we are, that this is an unprecedented level of expectations around how best to support these individuals and to guard against that rate of transmission in our most vulnerable residential settings. I would also just like to say, from a state level perspective, just to frame this, if I could, as you know, we are looking to develop modeling, and that is occurring on multiple fronts to better predict when we will start to see surge, what peak demand may look like in the various regions of the state, what that may require in terms of obviously ICU beds, ventilators, what that may create for expanded pressure for more expedited discharge, and the ripple effect throughout the healthcare delivery system. And certainly the additional requirements for PPE and staffing. We have a number of models that are helping to inform that decision making. Along with that, we'll be continuing to monitor the impact of the community mitigation strategies. A lot has occurred, as I've described, both at the state and county level. We now, of course, have a stay-at-home statewide order. Ideally, we will be monitoring that to determine its potential impact, the percentage impact it will have on bending the curve in Florida, which has a direct impact on the hospitalizations and certainly the pressure on the discharge to subacute settings. There are other strategies that we will continue to monitor to continue to support efforts to bend the curve. Additionally, we are getting the benefit of national expertise around data analytics and predictive analytics that will allow us to be more strategically focused on some of those at-risk populations. Certainly, as I've described, the most acute at-risk population, our elderly population, those with underlying medical conditions. But we will also be looking at additional modeling focused on individuals with chronic disease, comorbidities that will help to inform strategic deployment of resources in the community to both preempt the spread and exposure to COVID-19, to target the testing, and to support the public messaging that can help all of our efforts as we seek to bend the curve and to reduce the rate of transmission. Before I conclude, I will say I have had a chance, obviously, to take a look at the New York policy. My initial reaction was certainly not favorable. That is completely contrary to the stance that we have taken in Florida. We know that this is going to take collaboration between hospitals and subacute providers to make the best decisions, best clinically informed decisions to expand the availability of testing for individuals who are in the hospital that do need subacute, do need to be transferred back to subacute settings. And again, as I said, it may require some additional capacity to be established to support more timely discharge with the appropriate clinical and care supports. I appreciate what all of you are doing on the front lines. This is a time when we all are focused on not only getting through this together, but recognizing the level of collaboration that must be at every corner, the level of creativity that we must deploy in order to effectively meet the needs of those we serve. And I am grateful to all of you. Thank you.
Secretary, thank you very much. Will you be able to stay on the line until the conclusion?
I am here, and certainly my team is with me as well.
Well, it's wonderful to have that terrific team there. I think what you said is going to strike a note with upcoming presenters, and certainly we want you to be there for questions. So moving right along, and thanks for your timeliness. Kristen Vaughn McCabe-Klein. Dr. McCabe-Klein, are you there to speak on emergency room preparedness? Coming off mute, perhaps?
With a *6.
Can you hear me now?
Yes.
We can hear you.
Okay. So I want to thank Secretary Mayhew for her comments. Clearly, you know, on behalf of the Florida College of Emergency Physicians, this is a time when we need to come together across any silos, any divisions that currently exist in our imperfect health system across the continuum of care. This is a time when we need to come together, collaborate, and do collectively what is good for our patients, for those who take care of them, and for our community in general. So I appreciate those comments very much. I do want to say that I think, you know, in healthcare leadership at present, everyone has become a patient. Our administrators have become patients. Our physicians, our nurses, our frontline staff have become patients. The families that they go home to have become patients, as well as those that we are working very hard to take care of. So I think we need to be cognizant that there are needs on all sides, and we need to be very aware that everything that we do will have intended and unintended consequences. I think the emergency physicians across the state of Florida are going to work insofar as they are allowed based on quarantine criteria. And they are going home and they are asking others to stay at home, or I'm sorry, they're going to work and they're asking others to stay at home, which is the primary focus for our communities. I think there are some concerns that the emergency physicians have that are valid, and I think those are things that we need to work through collectively and together. In terms of our post-acute care, I think one of the things that we need to be very cognizant of is the surge that has yet to hit Florida. And when we look at the demographics in our patient population and across our state, we are not necessarily as densely populated in all areas of Florida as New York City, but the demographics of our state are very similar to Italy. So it would be very easy for our health system to become overwhelmed. And so we need to think about, again, what are the direct consequences of decisions that we make, but then what are the unintended consequences. When we look at some of the work that is being done on the emergency physician side, we are every day getting new updates around appropriate PPE utilization and conservation of those resources, and also the education of all of our staff so that we make sure that the frontline healthcare workers feel protected and feel safe when caring for patients who have undiagnosed or undetermined conditions at the time of presentation. And we're finding that there are many patients who come in for other conditions or other traumatic injuries, and in fact, those patients then go on because of community spread to have signs, symptoms, or test findings consistent with COVID-19. So we are trying very hard to work with the Florida Hospital Association. I believe that Kim Straight from FHA has been working with ACA to make sure that we have education. So we're doing that not only on the hospital side and the emergency department side, but I think that needs to start happening in the post-acute care setting as well, so that we know that the folks who are charged with taking care of our patients, despite their medical conditions, however contagious they may be, feel comfortable and confident in doing that. And again, those updates are coming minute by minute, hour by hour sometimes. So I think a huge part of this is just going to be instruction and education for our staff to make sure that we are all on the same page in terms of PPE utilization and reutilization. I think there's been some concern on the part of the emergency department, physicians, advanced practice clinicians, as well as nursing staff, with regard to patients who are being transferred from a skilled nursing facility to the emergency department and asked for evaluation of whatever complaint or symptom complex may exist, and then that patient not being able to return. An example of this would be a patient who has chronic COPD, who develops some worsening shortness of breath, is transferred to the emergency department, undergoes an evaluation. It's determined that the patient will not meet criteria for hospitalization, but because the patient has a respiratory complaint, then that patient is not being accepted back into the skilled nursing facility. So I think we need to be very conscious of what is reasonable, and if that patient does not otherwise have risk factors for COVID-19, that we're making sure that we're very diligent about accepting those patients back in, saying, hey, this patient had an ongoing symptom complex for years of time related to COPD that was not related to COVID-19, and so the fact that this patient is short of breath is not necessarily due to this pandemic, but maybe due to the patient's underlying disease state. So I will say that that's one general sentiment of the emergency department folks at present. I think one of the things that has been suggested by the emergency medicine physicians and advanced practice clinicians that I think would be very helpful is looking at increasing the amount of medical oversight on the part of the skilled nursing facility medical directors prior to sending a patient to the emergency department for evaluation. So, in the past, if any member of the frontline staff in a skilled nursing facility felt that the patient needed an emergent evaluation, it was not always clear that a medical director had to be involved in the decision to transfer that patient. Obviously, immediate life-threatening, limb-threatening conditions would not be included in this. But if there is someone who potentially has a discretionary condition and there is an opportunity to engage the medical directorship prior to making that transfer to the emergency department, as well as engaging both EMS and the emergency department, saying, hey, we have this person that's going to be sent, here's what we think needs to be evaluated, and we are or are not worried about COVID-19 in this particular patient. I think that would be helpful. In terms of our stewardship of resources, the emergency departments as well as the EMS community is really looking at how can we decrease the volume of patients who are coming to the emergency department and presenting to the hospital in general that would potentially create a hazardous environment there, both for healthcare workers as well as other patients. So in the EMS world, we're looking at non-transport protocols where we say, hey, we have this patient who otherwise under non-pandemic circumstances might have been transported to the hospital for evaluation, but we're saying you're not hypoxic, you don't have unstable vital signs. We recommend that you quarantine at home. Here's the number for the Department of Health. Here's the supportive care that we recommend for you. So that's not something that we would do under normal circumstances, but we are engaging some of those techniques to try and decrease the influx of patients who have flu-like symptoms that are safe to stay at home. Similarly, we have multiple healthcare systems across the state that are setting up alternate venues of care, such as tents that are off-site, so they might be in a parking lot or another area of the hospital property, but outside of the emergency department proper, and funneling patients who are appropriate for evaluation into that alternate venue of care so that they can be evaluated for stability. If they're appropriate for discharge, then they're discharged without potentially contaminating the emergency department environment where we may have patients who have strokes, heart disease, cancer, or other immunocompromised states that would make that a dangerous environment for them to be in. So I think a little bit of oversight around, just the judicial use of the emergency department and therefore the hospitals would be something that would be value added. And I think, the input of medical directorship, leadership, whether that's via telehealth, which now we know is going to be a much more viable option than it used to be, or the utilization of advanced practice clinicians in the skilled nursing facility environment, I think would be very helpful. The last thing that I want to mention is that, in looking at what the unintended consequences of our actions will be, what we understand and a very real reality and tangible reality that already existed in our emergency departments prior to the onset of the pandemic was ED overcrowding and ED boarding. And when we look at the very appropriate criteria that have been set forth in the communication tool that was approved by the FHA with regard to testing of patients who are going to be then transferred to either, as Secretary Mayhew mentioned, an alternate venue of care or the skilled nursing facility, we understand that our discharges will not be as timely as they were before. So understanding that our discharges will not necessarily be timely, we know that the ED overcrowding is going to worsen. And so again, that very judicious use of the emergency department is going to become very important. And we're going to have to all, across the continuum of care, become very comfortable with things that we've been very uncomfortable with in the past. These are, as Secretary Mayhew said, these are very unusual circumstances. You know, these are trying times for everyone, and so we need to sort of reset the gauges that we're using in terms of our utilization of resources.
So, Doctor, thank you very much. Will you also be able to stay on the call till conclusion?
I will, Ian. I'll be here the duration.
Well, I appreciate your very straightforward words. I think those of us who are, have been, and will be medical directors in long-term care might have been touched by your reference to the scope of responsibility as gatekeeper for medical directors in long-term care. So perhaps that will come up at the end, and I appreciate your clear and frank words. Thank you so much. So, Kim, you were referred to. Kim Street, are you there from the hospital preparedness perspective? Star 6.
Okay. Thank you, Dr. Hock. And I want to thank you guys for pulling together this call. And I want to thank AHCA and especially for their leadership around this work. It is very hard. It is soon when this started, a shout out to Debbie Franklin. We talked about this issue of the challenges with getting patients transferred to the skilled nursing facility. And we appreciate AHCA pulling together a discussion quickly on a Saturday to look at what we could do to help facilitate that. We recognize that the skilled nursing facilities and the assisted living facilities are scared. I think we're all scared, and we had hoped that this forum would result in better communication in terms of the status of the patient. And I think Secretary Mayhew said that the guidance is constantly changing. It is, and so every day we don't know if what we were told yesterday stands today, and I think that is another challenge, but it just is requiring that vigilance to stay on top of things. I think from the hospital perspective, it is the whole issue around the lab testing has been a major, major challenge, because with patients that we don't know their status, we have had to act like that they have had the virus. And so that in itself was requiring a lot of PPE. I want to thank the Department of Health and AHCA in facilitating the testing, the priority testing of the patients within the hospital, so we know their COVID status, and also healthcare workers, because we can't, I think one of our rarest resources right now, probably more so than ventilators, is going to be our healthcare workforce, and so they need to be protected. And so what we're hearing from the hospitals is that, if it goes to the state lab, the turnaround is quick. Many of the hospitals have gotten their capabilities up and going, but the challenge now is the availability of swabs and the reagents. And I know that the state is working diligently on getting those available. But I think one of the barriers and some of the challenges with discharging patients was not knowing their COVID status, and some of the labs taking upwards of 7 to 10 days. But I feel like the state really stepped up and removed that barrier. I think that, right now they're all looking at their surge planning, and as we know, the surge planning really needs to be on a community level, and so they're putting those pieces together. I think when we look back again, at the issue of discharging patients and patients coming to us, many of you guys remember when we worked on readmissions 10, 12 years ago, one of the novel concepts was this teleconsult to the skilled nursing facilities to do vitals, to check things to see, do they really need to go to the emergency room? And as we worked on the communication tool going back with Debbie and her team, one of the things first and foremost was to encourage the facilities to use this teleconsult, telehealth, before they send them to the emergency room. We're working on ways to increase PPE. Martha DeCastro, who is our VP for nursing, her background for many, many years before coming to Florida, to FHA, was infection prevention, and she's working with Duke on some of the disinfectant decontamination, so we can really use our PPE as much as possible. So we're working on that. And then I think we're just looking at all of the guidance that is coming out regarding use of scarce resources, our allocation of scarce resources in these times. And so we hope it doesn't get to that, but that's something that, we are looking closely at what other states have put together, what many of our hospitals have put together. But it is, I think it's going to require us all working together. And at the center of this, it's the patients and their families. So I also want to mention, with the barriers, and thank you, Secretary Mayhew, for all of the work around the Medicaid plans and waiving some of the administrative barrier or administrative work. And most the Medicaid plans have waived the requirement for prior auth. The same thing with the PASAR. And these are issues that we have dealt with over the years in terms of back and forth and, between the hospitals and the post-acute settings. Late Tuesday night, Florida Blue released their updated guidance, and they are no longer requiring prior auth for, the discharge to post-acute. And they did that for Medicare, their Medicare Advantage. They have done that for their commercial. They are working with their self-employed or the self-insured to try to get that in place, and then with the feds. So we're hoping some of those barriers will help facilitate easy and timely discharge. So, but I am honored to be on this call with everybody, and I want to thank all of the work that everyone is doing to take care of Floridians. And yes, I'll stay on the call.
Dr. Hock, are you there?
Oh, I must have put myself back on mute. I
didn't know if I left you speechless.
Well, of course you did, and thank you always for how you represent Florida Hospital and the concern for the frail and the elderly in the long-term care. So we've just appreciated that relationship so much, and thanks for your words here. And you mentioned Debbie Franklin, and Debbie, are you there to give us the nursing home perspective?
Yes, I am, Dr. Hock.
Well, thank you, and I'll go back to mute and know it.
Thank you. I'd just like to say a big thank you to FMDA for doing these stakeholder calls, these stakeholder meetings that we've done collaboration on, because that's how I began my relationship with Kim Strait, and it has been invaluable working together in the early days of this outbreak, working together in the collaboration, creating these tools to help in the field, and also communicating the things just like Dr. McCabe-Klein has said about the ER issues. I will let you know we have our regular calls, 1,000 lines, and they fill up with assisted living and skilled nursing facility. We joined in with all the other associations, Leading Age, Florida Senior Living, FAAHPM, to get all of their members to try and educate and get things out. And on the last call, I did talk about the emergency room issue, and also to talk about the telemedicine and using that and trying to keep that resident out of exposure by doing what you can to get them examined there and with their physician and the medical director. So we are working on that and recognize that that is an issue that we're trying to help prevent. The secretary has been awesome. I know tirelessly. I'm not sure if she's ever been able to sleep, along with the agency team. And it's been that collaboration, along with what we have here today of more collaboration, that will help us prevent the unintended consequences. We do have a heavy senior population in Florida. We have almost 700 skilled nursing facilities and 3,300 assisted living facilities. And the gamut of assisted living could be a 6-bed home that's been converted to a 200-bed assisted living. And part of the confusion is a lot of people don't even recognize what the difference is in a skilled nursing facility versus an assisted living, and what they're allowed to do or what they are supposed to do. So that's where we've joined forces in that collaboration to kind of try and help with that. And I appreciate this collaboration here, because that will continue to get down the barriers of communication, and those barriers is what causes the friction. And this is not like anything we've dealt with, and we have to put our normal operation aside. It's not how quickly can we get that bed empty. We have to look at the patient. Now more than ever, it must be person-centered care. We have to look at all the aspects, including the place we're discharging. Do they have the ability to take care of this patient on isolation? Can they do isolation? Can they do quarantine? Do they have just resident assistants in that assisted living, or is there a nurse? Because with all the levels of assisted living, that's a factor. And so all of that is what we've been trying to help with the education. Going back to the ER issue, and I'm trying to look at the education piece as to what can we put out there to help the fear. Someone talked about the fear. It is the fear. You know, they love their Mrs. Jones and Mr. Smiths and all their little residents, and they're fighting hard as a gatekeeper that COVID virus does not get to them, because they understand the risk. If we could have some education on how, when you do get someone in the ER, that you triage and you know, this is respiratory, goes this way, this one's not, I'm going to kind of try and prevent exposure. That might help a little bit with understanding that once those stitches are in from that little cut, you can get them right back. And so anything like that that you could help share with us, that I can get out for the education to help take away the fear. I really think the emergency room barrier is one that, you know, I'm trying to tackle, and I will assist with that. But I also would like to turn it over now to Rob Green, the CEO of Palm Gardens Healthcare. He is one of our quality providers, and would just like for him to, he's also the vice chair of our quality cabinet, and to just say a few words about the provider perspective from the field. Rob?
Good afternoon. Can you hear me?
Yes.
Yes,
Okay,
we can hear you.
Six word. Well, thank you so much for the support and the respect for you know, the post-acute guest residents and teams, Secretary Mayhew and State Agency Director Smoke and FHCA. You've been so supportive through this and understanding our needs and understanding the needs to protect the post-acute setting. If I could be as blunt as I need to be, you know, from a long-term care perspective, we must have some isolation strategies put in place if we were to take positive COVID patients. Palm Garden and I know many other providers have already put in small isolation areas to care for any potential positive COVID patients that we might have before and if they have to be discharged to a hospital setting. Another key piece is the supplies. We are very limited in the post-acute setting on supplies, primarily the N95 masks that our team members continue to ask for. And then the other piece was Kim had just talked about how the hospital systems have improved their testing. We still are not there yet. Our labs are still running anywhere from 5 to 12 days to get a test back. We are hearing from labs that quick testing is around the corner, but if that was made available sooner than later, we really could turn this corner and protect our frail elderly even better. So again, we as long-term care providers are here. We're part of the team. Our goal is to care for those in need, and we are bound to work together, improve the communication with the hospitals. And I do thank you for the comments regarding getting the medical directors and the ER systems working closer together. So thank you for this time.
Well, thank you for that, and thank everyone. We're right on time to open for questions and answers, and please speak up. I see the chat room has put a couple of questions in there. Secretary Mayhew, may I ask you a question? I just appreciate your clear understanding of the long-term care issues. I think you articulated them very well. We heard you voice our concerns. Do you think that other Florida state departments and agencies share your view of COVID in the long-term care space? Secretary Mayhew? How about Molly or Kim representing the state? Okay. So any other questions come up? Secretary Mayhew, is that you coming up? Yes.
Leonard, this is Joe Auslander. Can you hear me okay?
Hi, Joe. Yes.
Thank you for putting this together, and I appreciate everyone being on and especially the people from the state organizations. I have a suggestion that could be part of an action plan and a question about testing. My suggestion is that the American Medical Directors Association and the program that I developed called Interact have criteria for when doctors and advanced practice clinicians need to be notified versus when things could wait. We know that a lot of emergency department visits are unnecessary. One action step that could help mitigate overcrowding emergency departments would be to encourage providers to really look at those criteria and not send people to the emergency department who don't meet certain criteria for an acute level of illness. I recognize that COVID and other serious illnesses can present non-specifically, but I think those criteria are available and could mitigate overcrowding of emergency departments. The question is that I don't know the answer to this question. Let's assume that rapid testing becomes available. What are people's views on testing all residents and/or staff in facilities, assuming it becomes available?
This is Dr. McCabe.
Well, Joe,
can I address that for 1 second?
please do.
Okay, I just want to mention that, you know, one of the conversations that we've had on the emergency department side, and again, this is on behalf of the Florida College of Emergency Physicians, not FHA or any other organization, but one of the sort of sidebar conversations that the emergency department physicians have had is, you know, we've been very focused on developing sort of clean and dirty areas within the emergency department and then also within the hospitals. And so one of the thoughts that we have had and discussed amongst our leadership is a clean and dirty post-acute care setting. So if we know that we have healthcare workers who have become immune because of previous exposure with mild illness or even, you know, just being a non-symptomatic or asymptomatic carrier, but they have developed immunity, and that person would safely be able to take care of these patients, and then understanding that we have the ability to rapidly test folks who need to be discharged from the hospital into a post-acute care setting, you know, could we potentially have a COVID positive, you know, facility where we have healthcare workers that because of their own immunity are protected, and then we have patients that are appropriate for that setting cared for in that venue. And then we understand that we have other vulnerable populations as well as other vulnerable frontline healthcare workers and putting them in sort of a clean space, so to speak. So that is one of the conversations that we have, we've had sort of offline. Again, no formal statement or position statement on that, and definitely we've not had any conversation around that with other agencies, nor have we vetted that sentiment, but it just was a brainstorming sort of conversation.
Well, Dr. Leonard
Dr.
Hock here,
Hock.
I appreciate those words. I think that is an out there concept, but it's one that needs to be considered when we get to that time. For Dr. Oslander's criteria for admission, we always should look at that. I think Dr. McCabe-Klein, you mentioned that. Quick testing is going to be very important. If we could quick test in long-term care or even in the emergency room, we wouldn't have that 5 to 8 day delay that Kim spoke of. When you're in the hospital, unless you're negative, you're considered positive, and it uses up PPE, time, a hospital bed, and it's just difficult. I think Secretary Mayhew may have rejoined the call. Are you there?
Yes, I am, Ian. Thank you. If I could just comment on a couple of things. Can you hear me?
Yes.
Okay. So in terms of the testing, you know, again, we all recognize the shortages that we're facing with access to swabs, the challenges with getting some of the hospitals the resources that they need to set up hospital-based testing for COVID-19, but we've made a lot of progress on those fronts. What I would say, though, and the Surgeon General has made this clear, I have repeated it frequently, and that is that any individual that a clinician believes in the hospital that should be tested, they have the ability to request a PUI number and to have that test processed through the public health lab. And the turnaround time for those tests is between 24 and 48 hours. And we do want to make sure that that resource is being effectively leveraged, especially as we deal with the legitimate concerns about the vulnerability to infection and the transmission rate within a long-term care setting. So it is a clinical decision, and I have to say, and I know Kim made this comment as well, it is challenging for everyone on the front lines, you know, going from the original CDC guidance to where we are today, and the role that we're trying to play to support effective decision-making around testing and appropriate use of resources. But given the focus that we have as a state and as a country on protecting our most vulnerable, our elderly, those with underlying medical conditions, we do want to make sure that those tests are done and that they can be quickly processed through the public health lab. And of course, as I said, many hospitals have been able to thankfully, commit to and set up their hospital-based testing, which of course has a much quicker turnaround. I also wanted to comment on the statement about the medical directors and their role, and certainly want to echo the increased clinical engagement that we want to see to both oversee and deploy needed clinical support and services within the skilled nursing facilities, and certainly to support our assisted living facilities. But I would also say that when a resident or residents have been identified as potentially symptomatic, and a call is made to the county public health department, there are a series of events that may be occurring, and some of that may differ from county to county, but certainly there is an expectation both from the State Department of Health and at the county public health department that they are helping to support the decisions that facility needs to make regarding transfer. And I think that's important to underscore that the public health system is guiding a lot of those decisions about whether or not to transfer a resident to the hospital, to the ER. And I certainly understand that the challenge we all face is both, transferring someone who does not really need hospital level of care, but we are expediting that transfer out of the subacute setting, not only because of what they may need for care, but because of the great risk of transmission. And I think it was stated earlier that the challenge we have is this gap in availability of a interim step between the hospital and a return to that subacute setting. And that is what I mentioned earlier that I am working on with the associations, with local providers, and that is to potentially try to set up a recovery facility where it can appropriately have 14-day isolation and recovery care. So that we are absolutely looking at and exploring options to support that, along with the expedited testing that could help to support timely discharge and transfer back to the subacute setting. Thank you, Ian.
So, Secretary, I just want to say another word or two about that. Medical directors in long-term care, and this is back to Dr. McCabe-Klein's comments, assist with regulatory compliance, quality oversight, infection control, and the establishment of criteria for resident admission and sometimes discharge. But they've never been assigned, to my knowledge, the direct responsibility of individual patient gatekeeper for sending a patient out based on a change of condition or readmitting a patient that doesn't meet criteria. That would be the New York policy that's in place. So that'll be a whole new scope of thought to view the medical director of long-term care facilities as the individual resident gatekeeper for referrals out to the hospital, to the emergency room. But it's something for us to think about.
Ian, if I could just comment about that, and I absolutely hear you, and I think what I would ask, since we have created a lot of flexibility for individuals throughout the continuum of care, healthcare providers, direct care staff, to expand upon their current role and responsibilities to the extent that you all can contemplate what that might look like for medical directors. I think it is a critical role and resource that is vitally needed at this time. And, I think we're all concerned about the level of disruption that this is having on our traditional expectations of the healthcare delivery system. But in this unprecedented time, to the extent that you all could contemplate, evaluate, and provide perhaps some recommendations about how you might facilitate some of at least the clinical recommendations when an individual needs to be evaluated, how we might support. And again, I think for me, it is both their clinical care that needs to be addressed, but also the ability for the level of infection prevention and control that needs to be adhered to.
Yes, and Secretary Mayhew, this is Diane Sanders Cepeda. I want to just thank you for all of your comments and speak to, I know we're at time, but speak to what Dr. McCabe-Klein had mentioned about maybe designating a facility. You know, we are already in our preparations and preparing the medical staff who serves post-acute long-term care. We're having those discussions about creating isolation units in the facility, having a facility maybe designated as a place that can receive COVID positive patients versus COVID-19 naive facilities, if there are any that exist still. And we have had a very detailed conversation about being prepared and having a treatment plan in place if we do have residents who we could treat in place on those isolation wings. So we would definitely like to stay in lockstep with you and the state and all of the organizations that are being represented here on the call. I don't know if there is a COVID task force, preparedness task force that exists, but we would definitely like to be included in one if it does exist, because we want to make sure we could help develop those things that need to be put in place for post-acute long-term care preparedness.
Thank you for that. And I would just add, I think that's really important. And while there are a number of groups that are working at the state level to try to evaluate these various decisions, I am very interested, and either through this association or through the other associations, to get some feedback. I think there's some concern about even trying to create isolation wings because of the risk with staff coming and going and the ability to really contain the infection, the virus from that wing to the other wing. So I'm very interested in your thoughts about that. And I know that we've got to be creative in how we support those additional recovery type facilities, whether it can be as a wing or as a separate facility. So very interested in that, and we can talk offline with Ian and others about how best to facilitate that conversation.
Madam Secretary, this is Steve Wynn with the Florida Osteopathic Medical Association. I want to thank you and your team for always being available, and if we could be of any help as a statewide association to continue getting information out to our physicians and their patients as well, please use us anytime you need us.
Well, Steve, thank you.
Leonard, Hock here.
Can I just say to any of the associations on the phone, if there's an opportunity for us to speak and address any of your associations, I just want to offer that as a separate opportunity for us to communicate and engage.
Thank you, ma'am.
Secretary, thank you for that. And as a matter of fact, Ian, the executive director of Florida Medical Directors Association, will be following up with the participants on the call, because we do want support. We want collaboration. We want action items. As Dr. Diane Cepeda-Sanders just said, there needs to be a long-term care COVID response collaborative, and we want to be the hub and facilitate that. So thank you all for an hour-long enlightening conversation, some frank talk, and some new perspective on how we can be ready for the surge. So I just want to thank everyone for being on. Ian, do you have any closing statements before we say goodbye?
Well, certainly thank you for taking the time to join us today, and especially our speakers who had, in some cases, barely 24 to 48 hours to agree to do this. So thank you all. This has been some great information. As we move forward, we will follow up with you. We're looking for feedback. We're looking for strategic collaboration. And with that, I will say thank you and enjoy the rest of your day. We'll be talking soon.
And we thank you too.
Thank everyone.
Thank
Thank you. Goodbye.
Thank you.
Thank you.